Okay, well, thank you very much, Brian, and welcome everybody. I'm really delighted to be representing the Canadian Patient Safety Institute today, or CPSI, as we in the short version that we call ourselves, and wanting to share with you some of the great work that has been done in partnership in Canada around how we support healthcare workers through to keep their psychological health in a state that we all want it to be. So as I was preparing for this presentation, I'm just trying to advance my slide here. Sorry about that. Let's see here. So there we go. As I was preparing, I was doing some reflecting actually about crises that I had been through in my career. I've been around a long time in the healthcare system, and through a number of significant crises that happened during that time. And I go back and most of my career has been in Nova Scotia, and I go back to the first really large one was the Swiss Air disaster that happened in 1998 in Nova Scotia, and I was a vice president at the time and on call, and so had to set up our command center as we hopefully waited for casualties to come our way, and when none did, how we set up some search and rescue and temporary morgues, and having to deal with all of the families who are coming from around the world in hopes that there would be some news on their loved one. And then we went through SARS, and then we went through H1N1. And through all of those crises, I was thinking to myself, what did we learn? And how did we put in place supports for our staff who went through, right around the world, but certainly as I reflect in Canada, went through some pretty significant stressful times. And what really struck me is how much we underestimated the impact of those stressful events on our teams. It was really amazing how we just moved on. We just assumed people were resilient. We closed the chapter on those, and then we moved on without really, for the most part, taking the time to stop, to check in, to be sure people were okay, to put in place those resources to support them going forward. We just didn't stop to ask. We just carried on, as we so often do in healthcare. And so what we see now, as we are in this state of unprecedented crisis around the coronavirus, and I can't even begin to imagine what it's like for many of our frontline providers who are just in the thick of this. And we know that this disease and this pandemic is posing an extraordinary challenge to the health and well-being of people around the globe. And, we've got threats to social stability, economic prosperity, and human health. And that's just as individuals. That's not even as those healthcare providers who are dealing with the stress of going to work every single day and being so exhausted in what they're doing. So we know, our healthcare workers are a resilient lot. I started my career as a nurse. I understand what it feels like to be working on the front line, certainly not in these kinds of crises, but just the everyday stress of patient care is significant. But we think and we expect that our healthcare workers are going to be able to handle that. But what we do see is sometimes just these everyday stresses can really escalate, and certainly they escalate when we have, unexpected loss of patients, when we're in some ethical dilemmas, when perhaps we're having disagreements with some of our colleagues over care management, and it often results in our providers feeling psychologically and or emotionally really distressed. So we're a high stress environment. We expect that our healthcare workers are going to work efficiently and safely in difficult times and pressured times. When we look in Canada at our 2016 Statistics Canada data, which is really kind of the ones we still look towards, what that data told us at the time was it indicated a really high turnover rate amongst our care providers, and it was leading to a lot of job vacancies that we're still feeling in this country, because many people are leaving the profession. They can't deal with the day-to-day stresses that are there. And we know that people who are in any moral or psychological distress, we see the link. There is a correlation between patient safety incidents and the mental health and the mental stability of our workforce. So we know that the probability, if we don't deal with this, that the probability of increased patient safety in this incidents will only will happen. So what we've been doing at CPSI is working with our partners to identify some enabling and supportive organizational practices and policies for psychological health and safety. So we're doing this through peer support programs and developing resources to really help promote our healthcare workers, so that we can promote that healthcare worker well-being and safety, and that of patient safety as well. So the program that I'm going to describe to you in a little more detail is really intended for many audiences. It is intended to influence policymakers, organizations, regulators, and accreditation standards, really embedding this peer-to-peer support and support for our healthcare workers right into those kinds of sticks that we have. In our organization, we don't have a stick. We can just develop resources, tools, put them out there and hope that people take them. That's the way that we have been working for a number of years, until we realize that that is hugely important, but we also need to start to embed this right into the legislation, the accreditation policies, etc. So what we set out to do was to develop some best practice guidelines, tools, and resources that would help support healthcare leaders and our frontline healthcare providers and workers, where we set out to develop some Canadian best practices and really produce that comprehensive toolkit. I do want to say that we are a World Health Organization collaborating center for patient safety. We're really proud of that, and on patient engagement. We really enjoy working with World Health Organization and all of you around the world, and we're a proud ISQua member, so we are delighted, and I am really happy to be able to share our experience and our expertise and our resources with all of you and right around the world. So what we do at CPSI, for those of you who may not be as familiar with us, we work with governments, we work with healthcare organizations, leaders, healthcare providers, and what we're really trying to do is inspire extraordinary improvement in patient safety and quality. And we developed a new strategic plan at CPSI in 2018, so we're a few years into that, and our strategic direction, our plan is called Patient Safety Right Now. You see that on my slides. This is not about, not in 6 months, not in 6 years, but right now. Enough about harming people, enough about enough about not having safe care. We really need to get on this in a way that we haven't before, because we see around the world, despite the marvelous work that's happening, we aren't raising the bar in the way that we need to in patient safety. So we really have changed gears a bit at CPSI. We're still developing tools and resources, doing collaboratives, etc., which are extremely important. But what we've switched a little bit in our strategy is around informing policies, standards, really trying to up the game of patient safety and really embedding that patient safety requirement in all our regulation, standards, and accreditation. So in developing the national program for psychological health and safety of healthcare workers, we partnered with a wonderful partner of ours, the Mental Health Commission of Canada, and we brought together experts from all across the country to really address the needs of healthcare providers who've been traumatized by events during their provision of care. And we know what this has been called is second victim syndrome. So I'm going to really talk mostly about the tools and resources that we have developed specific to second victim phenomena. And for those who may not be familiar with that, in 2000, Dr. Albert Wu, who is a great friend of CPSI and a wonderful patient safety pioneer, He first coined that phrase of second victim, and he had written an opinion piece that was titled Medical Error, the Second Victim. The doctor who makes a mistake needs help too. So perhaps it's specific at that time to physicians, but knowing that all healthcare providers are here. So, and really, I think for the first time in an international way, acknowledging that we need to have some organizational support for the healthcare provider. So although the work that we have been doing was specific to those who had providers who have been engaged in unintentional harm, it really does have applicability for any healthcare provider who is in a stressful situation. So we know the second victim phenomena is real. It has serious consequences for healthcare, and there have been a number of different studies around this second victim phenomenon. It shows that healthcare providers will have identified anywhere between 10 and up to 43% of healthcare providers that this is the rate of prevalence in our healthcare system. What we came to realize is that there are, even though this is a huge issue, that a lot of people are acknowledging it now, there are really very few comprehensive programs around the world that are specifically designed to address second victim phenomena, and it was very sparse in Canada, so we knew that we had to do some specific work. And we also know the impact on healthcare providers is really quite profound. It affects their physical health, it affects their well-being, and it affects the safety of patient care. And we also know through literature that some providers, they may just suffer in silence and continue to do their work, really not letting anyone know that they're suffering. Some just leave the profession entirely because they can't cope. Some change their roles because they can't see themselves continuing. And we also know that very sadly that some people are even victims of suicide because of this. So knowing all of this, we decided at CPSI that we needed to do something about it and bring together people to develop the resources to help folks. I will also just mention that the term second victim doesn't ring very well with some of our patients and providers. They don't think that that really describes the full experience or what we're trying to think about. So we're all, I think, scrambling to say, what are the words that best describe this? What can we call it? We haven't landed on that yet. So you'll still see researchers and many people describing it as second victim. And until we have a different way to describe it, we'll continue to do that. I just want to introduce what we're doing in Canada, and we're learning from the leadership of many of you right around the world of what's happening. You can see up on the screen, we have, this is the national program, national in Canada, for the psychological health and safety of health workers. You see what our program goal is there. It really is about bringing together the right stakeholders to develop and design and develop and disseminate that comprehensive approach to addressing psychological health and safety of our healthcare workers. Our program, we have this targeted for a number of different audiences: policymakers, accreditation bodies, regulators. Those are really important that we want to target so they understand how important this is and can help us to develop this through the right policies, legislation, and standards, but also for our healthcare leaders to help them to design this, to get them to understand how important this is, and for our frontline providers. And what the whole program was about was to develop best practice guidelines, tools, and resources so that we could support healthcare leaders and frontline healthcare providers. So how did we go about doing this? Well, the first thing we did was conduct a pan-Canadian survey of healthcare providers. We wanted to be sure. We thought that the many great brains we brought around this project together, we had an idea of what people needed, but we wanted to check in with those actually who were designing the program to be sure that we absolutely understood what their needs were. And you can see on the left of the screen, these were the lists of the organizations who shared the data with their members. And we also had a number of our physician leaders and champions who circulated this within their own personal networks. So what the study uncovered was that what Canadian healthcare workers needed in terms of emotional support after they had been involved in a patient safety incident. We really wanted to get the perceptions of Canadian healthcare workers on their experiences, find out if they had in fact received support after being involved in a patient safety incident, and did they get what they needed, or could they give us some advice on what they wished they had received? And so this really was a basis for us on what are the existing support systems that are out there and that really assess the needs of healthcare workers. So we had a total of 390 frontline care providers who responded to the survey, and the disciplines that responded ranged from dietitians, medical lab technologists, nurses, paramedics, pharmacists, physicians, and respiratory therapists. So we had a good range of people who did that, who completed the survey. Just to give you a sense of some of the things that of the information that we gleaned from this survey, 58% of those who responded said they'd been involved in a serious patient safety event. 58%, that's pretty significant. A third of them, a little over a third, indicated that a patient safety event that they'd been involved in had caused them to experience anxiety and depression. So a whole third of them. Some even wondered if they could continue to do the job. So it was that profound an effect on them. Over 50% of them experienced embarrassment. They were embarrassed in front of their peers, in front of patients, in front of anybody who were there. It was just really significant for them. 54% of them indicated that the experience made them fearful of future occurrences. We've done a number of videos with care providers who've been involved in unintentionally harming patients, and almost all of them speak to that if they're in a similar situation after the event has happened that was similar to when the event, they start to lose confidence, they get panicky, they almost have post-traumatic stress disorder symptoms. So this is really significant. 40% of them said they just felt miserable because of the experience. 41% felt deep remorse, and that the same amount, 41%, said it made them hard to sleep regularly at night. And here's what's the saddest part for me, that only 6.5% of respondents indicated that they had received any kind of support at their institution. You know, as I mentioned earlier, I've been in healthcare a long time, and I was CEO at a health authority in Nova Scotia for almost 9 years. And we prided ourselves on how we were disclosing when an event when an error happened and an event took place in our organization. We prided ourselves in how open and transparent we were. We prided ourselves in how we wrapped our arms around the patients and their families and met with them and followed with them. And we learned as we went along. We got better as we went. But here's one of the things I would say is a failure of my leadership, and it will sit with me and probably why I am so passionate about this work now, is not once did I reach out as a CEO of that organization to staff who had been involved in harming patients unintentionally. Not once. I assumed that whoever they were reporting, whoever their superiors were, that they were doing that. I paid a lot of attention to patients and families. I paid a lot of attention to the public in disclosing what had happened, but not once did I think about the person who was involved and the impact on them. And I will forever be sorry that was the case, but we need to change that. And I think that's probably an experience of many leaders. So we absolutely need to change that. And if I were to ask you in your organization, if you were to do that survey of healthcare providers, what do you think the numbers would be? Do you think they might be similar to what our national survey said? Well, most of the literature points to it's pretty consistent. across. So there may be some of you who are doing outstanding work, but I think the vast majority of us, there's room for improvement in how we go forward. So the results of the survey really emphasized for us the importance of creating that awareness for support. So what we're really hoping is that healthcare organizations will pay attention to what healthcare providers are expressing through this survey, and will really make use of the tools that we have put together for their use. So the next step we did, in an effort to learn from those who've already implemented peer support programs around the world, we wanted to learn from them. So we conducted an environmental scan of national and international literature. We worked with a team of researchers from Dalhousie University, which is a university in Nova Scotia, and with the IWK Health Centre, which is a women's and children's hospital in Nova Scotia. And they conducted a scoping study to really explore how health professionals are supported after a patient safety incident. So what this study really explored for us, they looked at the range and context of interventions used in Canada and internationally to support health professionals emotionally in the workplace. And specifically, we asked to describe programs that address the impact of patient safety incidents. We wanted to describe the target audience of the intervention. And we also wanted to know, did the interventions make sense? What were the outcomes of the innovation? So did they help or not? And what we did find out is that innovations in healthcare, such as peer support programs, are sparse across the country. There are some pockets of excellence around the world and in Canada, but we aren't sharing, we aren't spreading and scaling, and we really knew that we needed to start to provide that broad overview of interventions used throughout the world, so that we could all learn from that and improve. So here are some of the tools that we have developed and resources that I will say a number of times throughout this presentation are all on the CPS website. They are all available to download, and they are free for you to use, and we'd be thrilled if you would use them. One of the first challenges that many organizations confront in exploring a support program is really that ambiguity surrounding what kind of protection legally do staff have around disclosure. And many front line care providers, particularly our physician colleagues, are often coached or advised to not disclose in peer-to-peer support programs. So we wanted to really look at this, because people would say, well, what about malpractice actions? What about if I start to talk about this, will I be, have a professional disciplinary hearing? So we wanted to truly understand where programs that are already up and running stand regarding employment or college disciplinary proceedings. And we wanted to give people the information about what they could disclose, what they could talk about. So we created a safe space disclosure guidelines, and what this document does is it really clarifies the legal privilege and professional confidentiality considerations of implementing peer-to-peer support programs for healthcare professionals. Our hope is that this work will really help healthcare organizations be very open about this, create those psychologically safe support programs. We want to be able to assist health professionals who are seeking support to understand what's protected and what's not. That's really important for them to feel very open and to be able to enter into dialogue to help themselves. And important for by doing this, to enable patients to gain insight into health professionals' experience. And of course, we want to encourage policymakers to consider what they might need to do to help, right? Are there changes, including enhanced protections for these communications, that policymakers could assist with, so that we're sure that healthcare professionals are being supported? So, once we looked at the result of the Pan-Canadian survey and we looked at the global environmental scan, it was very clear to us, if it hadn't been before, it sure was now, this validated for us that there was a huge need for establishing peer support programs in healthcare organizations in our country. So we knew that we absolutely needed to have these established if we were going to provide the supports that our health care providers needed. So what we did, we worked with Canadian experts in the field to develop this best practices chapter of the Creating a Safe Space manuscript. And we recruited people to help us with this because of their expertise in establishing their own peer support program. We had an advisory group that helped shape the direction and the content of the manual. The members gave us, they were so incredibly generous with their time and their talent. They gave us advice on important elements to include in the document. They shared a ton of resources and tools with us. They outlined tips and lessons learned, and they worked really closely with us to develop key messages and recommendations that would help organizations succeed. And these are all published on our website for you to use if you wish to. So it really is our aim throughout all of this work that these tools will be used to help influence policymakers and regulators to really support the work of healthcare leaders and practices. And we hope that we'll be able to bring together a community of practice where we can collaborate and learn from each other's experience for sure going forward. We also developed a toolkit. So we want everybody to have the tool belt with all the right tools in it in order to help with the peer-to-peer support programs. So we gathered resources from organizations around the world and from our best practices working group. And we developed this toolkit in partnership, again, with the Mental Health Commission of Canada. And the aim was to facilitate peer-to-peer support programs across Canada, intended for the same groups that I've talked about. And it really is, the toolkit specifically is to support healthcare leaders. This is about helping them to develop, to implement, or if they already have something in place, to improve their workplace peer-to-peer support program for healthcare providers. So it includes tools. It's really a how-to for you. There are tools, there are resources and templates from organizations around the globe. So we've highlighted some of the better better programs in organizations right around the world with links to all of the information about those programs to help people find what works best for them and how they shape that in the context in which they're working. And finally, as part of the work that we've done, we developed a webinar series on peer support programs. So we really wanted to showcase this program that had been developed. And so we launched last year a 5-part webinar series. There are the topics that we covered in the first one was around confidentiality and legal privilege. There was huge uptake on all of these. That was one that was very popular. We did a webinar on the results of the Pan-Canadian survey so people understood the lay of the land where we currently are. We did a webinar on global environmental scans so that we could share what was happening around the world and where some of the best practices were. We did one specifically on Canadian best practices. And lastly, we launched the toolkit for the peer-to-peer support programs. Excuse me, these webinars are, you can find this series and you can listen to them anytime on our website, which is patientsafetyinstitute.ca. I do want to give credit and a huge shout out to one particular program that is really doing some exceptional work responding to the COVID-19 crisis. And this is the RISE program that comes out of Johns Hopkins Hospital. This is, again, Albert Wu's fingerprints are all over this one, and he's been a great pioneer in this work. So a shout out again to Albert. But Johns Hopkins, this is a confidential peer support program that responds to calls 24/7. And it provides that in-person psychological first aid and emotional support to healthcare workers who are experiencing stressful clinical events. So this is not specific to being involved in a patient safety incident or unintended harm. This is really about anything stressful that's happening. And, when we were doing our research and our work and talking with our healthcare providers, what they told us over and over again is, yes, when we're involved in harm, we absolutely need some help and we need some support in the work that we do, but many of them said every single day we have such stressful situations that we're involved in such trauma. We need something available to us that it doesn't matter what the stress is we're going through. And so I think this program that Johns Hopkins, the RISE program, is really paying such close attention to this. In the past 5 years, this program has been replicated in more than 30 US hospitals, and it's helped thousands of workers. So it works. There's great evidence to demonstrate that it is. But for its COVID-19 response, these are good tips, I think, for all of us. RISE coordinates with employee assistants and the hospital wellness programs, chaplains, and psychiatrists. So it brings together all of those resources. And the team members, they approach high acuity units proactively. So they're in the ICUs, they're in the emergency departments, but they're responding in person to pages from individuals and groups, and they're offering them immediate phone support to the callers. They're paying attention to less visible units too that aren't your typical ones that we'd be thinking about, such as the microbiology lab that is doing a huge amount of work through COVID, transport, who are, pharmacy. So they've used this strategy that's been really successful for them about pairing infection control personnel who provide updates with the RISE responders who are giving the emotional support. And so the other interesting part about this is that they're also monitoring the command center, where the senior leaders and staff they're working long shifts. And having been in command centers a number of times personally, I know how stressful this is, and we don't often think about these folks. You are making decisions constantly, really tough decisions sometimes. In those command centers, they're under stress, they're going 24/7. These are areas where, people are, and sometimes you make decisions and in retrospect, they weren't the best decisions, but you made the best decision you had with the information you had at the time. So huge stress happening, and we often forget about our leaders and how difficult this time is for them too. So, really, I think this is a wonderful program that we can all learn from, and certainly how they're responding. And I'm sure many of you are doing similar things in your organization. So let's just understand. We all understand this. The response to COVID-19. It is a marathon. It's not a sprint. We're in this for the long haul. We truly are. So we need to pace ourselves, and we need to pace our responses to this. But I think we underestimate what the impact of COVID is going to have on all of us, but particularly our frontline providers when all this is said and done. And I'm just going to quickly use my daughter as an example here. My daughter is a nurse who works in the community here in Nova Scotia. She is a single mother of 3 boys. The husband has not been in the picture for a long time. She is barely holding it together. The moral dilemmas that she is placed under, of her feeling that she has to go to work every single day. She loves her clients. She's absolutely committed to that. But leaving behind 3 boys who are fending for themselves because there's nobody to babysit. They're old enough to do that. They're 14, 11, and 9. So they've learned a lot through that time. But her terror of being exposed and bringing that home to her children. What if she gets sick? Who's going to look after them? My husband has COPD. He can't be exposed. I've just recently had cancer surgery, so it was wise for me not to be exposed. We live an hour and a half apart from our daughter. Every day we talk on the phone, and every day she says to me, "Mom, I'm barely holding it together. I'm afraid that if I start to cry, I'll never stop." I think she is like millions of care providers around this world. Maybe others have more supports. She's on her own. She, other than the support we can give over the phone or from our social distancing, a wave from the car or to the from her front to her driveway to her front door every now and then when we come into the city. But I am so worried about her and all of the care providers that once this is behind us, how are we going to be able to support them? We can't just close the door and move on. We can't just move on. And this is going to be a situation right across our around our world, let alone across our country and within our provinces. So we need to be thinking now about how we're supporting people. We also need to be thinking when COVID is behind us, how are we going to support the trauma that so many of our care providers have been through? And developing these peer-to-peer support programs are, I think, a great way for us to be thinking about doing that. You know, I'm part of this kind of group chat or listserv of healthcare, of patient safety leaders around the world, and we often are sharing what's happening on a rapid basis and doing a lot of talking lately about the psychological health and safety of our care providers. And one of the individuals who's responded said, you know, if you aren't experiencing stress, there may be something wrong with you. And I thought to myself, wow, that is so true. Because every single one of us, whether we're in the healthcare system or not, are experiencing stress throughout this, but particularly our healthcare providers. So it is rampant, and we have an opportunity to do something very useful and help. As leaders, and all of you are leaders who are on this call, or you wouldn't be here learning, we need to show gratitude on a daily basis, sincere gratitude to our frontline care providers and everybody who is helping through this. We need to acknowledge that stress is a major issue here, and we need to have supports in place to be able to help them. And we need to be preparing for the aftermath. We've got to address this right now. So just in summary here, our resources around creating safe space, addressing the psychological safety of our workers. You see in front of you there our website. All of these resources are open to you. They are free to use. Please use them. It's really important for us. We want to be able to share with you. Don't hesitate to reach out to any of our amazing team at CPSI who can certainly assist you or guide you in the right direction. I will also say that this is just part of the work that we do at CPSI. It is incredibly important for us to be able to support our healthcare workers, support each other, but we have many, many other tools and resources that are there for your use. So I am going to stop there and turn it back to Brian, and would be thrilled to hear any questions anyone might have, or if you are doing some great work in your particular organization or country or province or state or wherever you're doing your work. I think everybody on the line would be delighted to hear that as well. So thank you very much.
Excellent. Thank you so much, Chris, for a fantastic presentation. There's been so many comments coming in here echoing those sentiments. So extremely well done on an excellent presentation, and thank you so much. So we do have plenty of questions coming in here. I'll jump straight into them now. Our first question is from Ilya, who has asked, what do you think about a nurse's paradox of being burnt out and overwhelmed, but also having job satisfaction at the same time? To work hard and be traumatized during stressful times of epidemic, but also to report to work in spite of everything that's going on?
Well, it is a dilemma, isn't it, for sure? And having been a nurse and not worked in anything like COVID-19 for sure, but feeling that push and pull, right? You love your profession, you want to be doing the best that you can, but you are so stressed and so burnt out. And, you know, we all have a part to play in this, but I think as leaders and those who are running organizations, we need to be paying far more attention to this and creating those spaces for people to heal and and to get well. I just a huge the answer is not easy to this one. I think we just need to acknowledge that it's enormous and that we need to start to put in place resources to support it, because it's been the expectation of the healthcare system that despite being burnt out, despite being stressed, you are going to show up for work and give 110%. And how can we? You know, you are true heroes. There's no question. All of certainly our healthcare workers are, but you know, our nurses and physicians are 24/7 around the clock, as are many of our health professionals. And I don't think there would be many who aren't facing the same kinds of things. So it's a dilemma. We've known about it. We have ignored it, I think, largely as a healthcare system, and it's time, right? We can't go backward, but we can sure go forward.
Excellent, thanks, Chris. Our next question is from Ida, who's asked, is your survey open for use by any organization or healthcare facility?
So that's a great question. I'll have to get you the answer to that. We have it. I know it's not open sourced and it's not there for use, but I would certainly think we would be able to share that. So let me find out about that, and perhaps Brian, through you, we could somehow post that, or maybe even on our website. We'll figure out a way to get the answer to you.
Yeah, no problem. Ida, if you'd like to email myself and Caroline at fellowship@isqua.org, we can pass on the information to you as soon as we have it. Our next question, Peter has asked, how can we also look at the impact on management? So looking at third and fourth victims.
Yeah, Peter, that is absolutely great. And I did allude to that in the presentation, that we often forget our managers and our leaders who are under unbelievable stress here, and paying a lot of attention to our frontline staff. Our peer-to-peer support program would be open to anybody. Would be the intention. Perhaps maybe a little bit more difficult for managers to have conversations with people who may not feel are their peers, but I think that's part of the beauty of this program. We could set it up in any way so that we are making sure that we are paying attention to whoever works within the healthcare system who needs some psychological assistance and support.
Great, thank you, Chris. Our next question from Sarfaraz. They've asked, what do we do with a silent second victim? How do we cope, or how do we deal with someone who remains silent?
Well, when incidents happen in healthcare systems, people know about it, right? So I think as colleagues, we should be reaching out to the colleagues who have been involved in those situations. I can remember being as a nurse when adverse events happened, and often we just didn't talk about it. We didn't support each other. We didn't talk about it. We thought, there, but for the grace of God, go I. People just kind of buried those things. And in retrospect, how difficult that must have been. So, when it's safe to reach out and hug when we're not social distancing, I think having those conversations, being there to support our colleagues who have been involved in there, listening to them, I think we really encouraging them to seek some help, because we know that suffering in silence isn't good for any of us.
Perfect, thank you, Chris. Our next question from Irene, who wonders about the term victim itself, as it suggests some level of intentionality or something's been done to them with a blame or shame mentality, whereas on the whole errors are usually non-intentional. What would be your take on the term second victim, the victim element of it?
Yes. Yeah, so we don't like the term at all, and we've been searching for, some other way to describe it, but the other way we've described it is like a whole sentence, so that doesn't work. You need something short and snappy, but we don't like the term second victim, just exactly for that reason. Both patients and providers have said that they have had an adverse reaction almost to that. It works for some, but not for others, and you're absolutely right. This is not about victimizing anybody in in this particular work. So if you have a suggestion, or any of you have suggestions for a term that might more appropriately speak to those who've been involved in unintentionally harming or have been harmed, then please send it to us, or make those suggestions here through the chat box, because we are looking for something that better describes it in a more positive, moving forward kind of way.
Sure, I can just see in the chat box here, Ming Ka has said, what about second impact? That could be an option.
Yeah, that's I like that. Yeah.
Yeah, guys, we invite everyone here to pop that in the chat box if they want to have a think about that as we progress through our Q&A. David has a very interesting question now. In support of the term second victim of patient safety incidents, would you see the healthcare funder or taxpayer as the third victim and fourth victims, or other future patients whose care can now not be funded as a result of the incident? So looking at a I don't know, a bigger picture, a wider impact scale.
Yeah, you know, so many people are impacted when things like this happen. We know, and we've been, you know, very appropriately so over the last number of years, have been focused on the patient and family. And that's been wonderful work, and it continues because it needs to continue, because we aren't there yet. But I think I'm so happy that we finally have a recognition that those who were involved in unintentionally harming somebody also need to have the supports. And you're right, there is, you know, an effect on many people when these things happen. So perhaps we just have to stop even naming those, but put in place the supports for anybody who needs them. And that's really the intention of peer-to-peer support.
Great, thank you, Chris. Ilya, also a very interesting question or insight here. What do you think on the effect of being perceived as a hero during the COVID-19 epidemic and its psychological impact in the short and long term?
Well, it's interesting, isn't it? And as healthcare providers, we're a humble lot, right? We just do it because that's been our calling, or it's our job, and we feel really important to do it. And how lovely is it that people right around the world are recognizing our healthcare providers as heroes. And I believe that they are. So, but what will be the impact? What's the letdown of that? What's the impact of that when we all go back to whatever our new normal will be? So I personally don't see anything wrong. I think hailing our healthcare workers who are doing amazing work through this time is absolutely appropriate. And they need that kind of support. They need to be lifted every single day. But it'll be interesting to see if there's an impact of that, and if there is a big letdown when all of this goes back, because they will be no less dedicated in the work that they're doing post-COVID than they are during it. Great, thanks, Chris.
Just seeing a few comments coming in here saying they like the term second impact. Second impact sounds good. So that's an interesting option.
Oh, well, that's, yeah, great suggestion.
Yeah. Our next question from Sarah, she's asked, what do you think about involving patients in risk management committees?
I think it's a fabulous idea. I will tell you that when I worked at Capital Health in Nova Scotia as the CEO, we made a commitment, and I think we were early adopters of this, certainly in our country, but maybe even around the world, on being open and transparent, and including patients on every committee that we had within the organization. I think it's truly important. They help us to understand in a way that we can't. We think we know what's best, and we know lots of what's best, but involving patients and the public in things like risk management committees, our quality committees, they help us to understand what's important. They help us to ask the right questions. They shouldn't be a threat to any of us, and I think it's absolutely the direction that all of us should be moving in.
Excellent, thanks, Chris. Our next question is from Andre in Portugal, who said, great presentation. Considering the need to protect those who protect others, what is your perception regarding the long hours of work and the already known elevated rates of depression, anxiety, and even suicides linked to job stress? How do we deal with these challenges in countries or services where there's not enough professionals to promote care for the high patient demands that they receive?
Yeah, so this is a major issue even in countries where we have enough professionals, because we're working long hours. 12-hour shifts are, I will say this as wearing my patient safety hat, are not safe. I worked them. I was manager for people who did. I saw and experienced myself how less effective you are. 12 hours to be on is too long now, and we see people who are working 24 and longer shifts through all of this COVID. We need to have some different solutions. We need to be thinking differently in healthcare about what's safe, not what. And you know, it's interesting when, as a leader, when we tried to even suggest a change, the length of shifts of 12 hours of many of our professionals, not just nurses, but many of our professionals, and say that's too long. Let's go back to a more reasonable time frame so that you can stay safe and stay well. Huge pushback, because people, you know, their lives had been they had created the routines of their lives around that, in terms of babysitting, in terms of time off. And so huge pushback. And I understand the importance of those kinds of things, but I think we need to come back to what is safe. And when we don't have enough care providers, what are other options? So we tend to still think, many of us, I think some of you in your countries have been hugely creative, but let's start to think about some of the not so usual suspects. So what are some other ways we can start to provide care, other kinds of care providers, so that we can spread that work? And I think, you know, there will be lots of silver linings in this pandemic that we're going through. It is teaching us how to work differently. It's teaching, you know, many of us have the, I think, privilege, I would say, of being able to work at home through all of this. So frontline care providers can't do that, but how can we free up some of the time that our frontline care providers are engaged in care by other methods like virtual care and other kinds of things? Our physicians, we're starting to learn some different ways through my healthcare experience over the last little while. Much of what I'm doing is virtual, taking pictures, showing it, you know, sending it to my physician, having those conversations over the telephone. Very different ways than having to show up in person. So how we start to kind of decant some of that that we can do with technology, and start to focus for the in-person care we need, being very, very specific. So it's an enormous challenge. We see shortages right around the world, even in Canada, the US, you know, all of our countries are seeing shortages. And I think they're going to be greater when COVID is over, because so many people will be affected and need time. And so we've got to get smart fast about how we're going to address that so we can deliver safe care.
Excellent. Thank you, Chris. I'm just conscious of the time now. We were a little bit late starting, so maybe we'll have time for one more question, if that's okay with you, Chris.
Yes, certainly.
Great, thanks. So John has asked, has anyone done a business case for this, and kind of highlighting any return on investment for it?
So we have not at CPSI. We just are addressing what we know is a need. And but I don't know, John, the answer to that, if there has been, you know, if other organizations have done a business case for that. My gut tells me that that it would be a phenomenal return on investment, but having not crunched numbers, I can't say that. I just intuitively believe that that would be the case.
Great, thanks, Chris. Okay, we'll go for one more. ISQua has asked, how would you tackle a blame culture within the organization and community? As we know, errors have many reasons, such as education, working environment, similar materials, and so on. So yeah, how would you tackle the blame culture?
So we have a wonderful tool at CPSI, again on our website, that is meant for leaders. We started out doing it for CEO and senior leaders like vice presidents, but wherever you are in the healthcare system, you'll see yourself. Even our patients have seen yourself. And it talks all about creating that culture of safety. And it is a tool. It's a toolkit. It's a check, almost like a checklist, and that says these are the kinds of things you need to have in place to have a true culture of safety. And it speaks to that blaming culture. We're trying to get away. Absolutely, we've all been working so hard to get to that just culture. I would encourage you to go there. There's lots of different things written. The reason that we put that together is it's confusing, and many of our leaders in this country said to us, of course we want to have a just culture. Of course we want to have a culture of safety. I don't even know where to begin. I don't even know where to start. What would that look like? What are those components? So that's why we put this together. So I would encourage you to go on, look at that. That will help you to give you some ideas about some tools, some resources, some ways to start to shift your culture from being that blaming culture to one of being open, transparent, and just from a safety perspective.